And so even though only about 1/3 of the people who are on the Medicaid program are older and in a nursing home, that represents about 2/3 of the cost of that program. So what you end up with by the time you get to the current health reform debate is most people have employer-based private health insurance, but that's starting to go away because even though you have a tax subsidy, employers find it increasingly hard to offer affordable insurance. A lot of people who are offered insurance at their job end up turning it down because what's happened is the premiums, the amount you have to pay every year, keeps going up. The co-pays and the deductibles keep going up, and so it turns out it's really expensive. And particularly if you're younger and you think, you know, maybe you can get away without having health insurance for a year because you don't think you're going to get sick, you may just say, forget it, I'd rather have the cash, right? Because if you don't have to pay for the health insurance, you'll just get additional money in salary. Now that's kind of a bad deal because that money is going to be taxed, unlike the insurance money, but still, you may just need the additional cash and not be able to afford the insurance. So we've gone from, in 1989, I think there were 23 million people with no health insurance in the US. And now there are about 47 million with no health insurance in the US. At the same time, the number and the percentage of people who qualify for Medicare has gone up because the population has gotten older. The number of people who are covered by Medicaid has actually gone up a lot too because the states and the federal government have expanded that program for poor people. But nonetheless, the percentage of people without insurance has also gone up because you've had such a shrinking of employer-based health insurance. So that's kind of the mess. In addition to all that, you have the most expensive health system in the world. And it's expensive for a whole bunch of reasons. One reason is that, well, it's fragmented and not very well coordinated. Another big reason is price. Doctors make more money in the US than any place in the world. Hospitals are reimbursed at a higher rate. Pharmaceutical companies are reimbursed at a higher rate. The drugs cost more in the US than anywhere else. Medical devices cost more than anybody else, in part because, unlike most countries that are able to negotiate price through either sickness funds or a single-payer system like the Canadian provinces, no one's really negotiating price very effectively within the US. It's very fragmented. You also have a sicker population than lots of other countries. And so one of the things that Dan and I discovered along with our colleague Victor Rodwin is if you compare the US to France and you look at heart surgeries, what you find is that once you control for need, once you control for the rate of heart disease, the French are actually receiving heart surgeries at the same rate as we are in the US, because the rate of heart disease is very low in France. But if you look at most graphs, if you look at most studies, they'll say, ah, the US is an outlier. We provide far more heart surgeries than any other country. And that's true. But it's mostly because we have more heart disease.
Maybe you have to just elaborate a bit on that. You said on need, based on needs.
We did a couple things, but one of the things we did, we were sitting around one day and we thought, well, this is kind of peculiar that we talk about rates per 100,000 in heart surgery, because isn't the relevant point how many people who need heart surgeries are getting heart surgeries? And it's actually really hard to get at that with the kind of data we look at. So all we did is we took a rate of heart surgery in the numerator, and we put it over the rate of heart attacks in the denominator. And we actually stuck a bunch of things in the denominator just to test it out. We looked at all congestive heart failure. We looked at all coronary artery disease, anything you can imagine. Heart attacks works really well as an indicator just because in most countries in the world they use the same clinical indicators for the diagnosis. And it just kind of holds constant the rate of heart disease. I don't know what the relationship is between heart attacks and underlying heart disease, but it's probably about the same everywhere. And so when you do that, the ratio looks identical in France. In fact, in our cities, right, the cool thing about studying these cities is that these are all places where you have lots of doctors and lots of hospitals and medical schools, so there are tons of doctors and hospitals in Paris. So if you just look at Paris and you compare it to Manhattan, where you are right now, it turns out Parisians are actually receiving more heart surgeries, controlling for need in that crude way, than people living in Manhattan. The reason that's the case is mostly insurance coverage. Because if you look at people with private insurance in Manhattan, that ratio looks almost identical to the ratio in Paris. But people who have no insurance, or people who are on one of the public insurance programs in the US, are far less likely to receive those kinds of surgeries. We looked at people 35 and over who are hospitalized in New York with some form of heart disease. And we did this big, long analysis controlling for lots of stuff like age and gender and race, ethnicity, where you live, your education levels, this kind of thing. And it turns out that people with no insurance and people on public insurance are significantly less likely than people in private insurance to receive a heart surgery even after they've been hospitalized because of ability to pay. And also it's a reflection of the fact that by the time you get into the hospital, if you have no insurance, you're probably very sick. So you're a bad candidate for surgery. So that's the situation we're facing. And what the current reforms have tried to do in many ways is to try to figure out how they could extend insurance coverage to more people while avoiding some of the fights that they've had in the past and some of the failures that we've had in the past. Harry Truman in the 1940s tried multiple times to adopt national health insurance, and it was killed every time. In the 70s, we played around with the idea, and it never got anywhere in Congress. And as you may know, in the early 1990s, when President Clinton was in office, he tried to invent yet another kind of proposal where they were going to change the way healthcare was delivered. They were going to create big regional alliances that would purchase health insurance for people and provide people with a choice of insurer. And this was rejected, and it was defeated within the Congress. And there are a bunch of reasons for that. One of them was that the Clinton administration didn't do a very good job of working with Congress. A bigger reason, quite frankly, is that they didn't have the votes. I mean, what you may or may not know about the US political system is it's also very fragmented. And there are lots of what we call in political science veto points. Basically, if you want to get anything through the US Congress, you not only have to get past the House of Representatives, you have to get past the US Senate. If you get past both of those bodies, you have to have a single bill that's worded identically, and then that is sent to the president. And it can get caught up anywhere along the line. A special kind of problem we have in the US is something called the filibuster in the Senate. Basically, it means you can talk a bill to death. Any individual senator, there are only 100 senators, can get up and just start giving a speech forever and delay a vote on something, and essentially, or a block of them, can continue to talk until and never allow a vote to take place. And if that happens, you can never get anything passed. The only way to stop that from happening is this funny mechanism, this funny parliamentary move called invoking cloture. 14 senators have to sign a letter and turn it in asking for a vote of cloture. They take a vote. If 60 senators vote to stop debate, debate has to end after a given period of time, and the bill under consideration has to come up for a vote. That means in the US Senate, in order to get anything done, you have to have a really large majority. It's not enough to have 51 out of 100 votes. You have to have 60. That was the big deal that took place and is taking place now with this kind of peculiar mechanism called budget reconciliation. Several years ago, in order to get a handle on the budget deficit, they put in place a special procedure for passing these kind of omnibus bills that included a bunch of different provisions that would influence the budget.